going to talk about is the typical neurological consultation. The three major diagnoses that we'd see in outpatients are people with a seizure and epilepsy, people with headaches, and people with dizzy spells. Now, of course, we see all the conditions like Parkinson's and MS as well, but the three most common conditions we see in neurology outpatients are epilepsy, migraine or headaches, and dizzy spells. They'd be what we call the bread and butter of neurology and the bulk of our referrals. So we're going to take headache as an example, and Donica suffers from headache, so I'm going to use him, if he doesn't mind, as an example of how I approach it normally. Whether that's the right or the wrong way is open to conjecture. But in essence, the very first thing we always get is a letter, either from a colleague in the hospital or more likely a GP. And the GP will send in a letter to us and we'll say, oh, that looks urgent, we better see this person quickly. The most important thing that people do or should do but don't do is read the doctor's letter. The patient has already been seen by a doctor and thus who will know the patient better than you will know them, of course, because you're meeting them for the first time. So the point is to read carefully the general practitioner's referral letter. From that you might get a flavour of what the GP thinks and the past medical history. In addition, the second most important thing I think after reading the GP's information is to find out what medication the patient is on, because patients will neglect to tell you that they're on antihypertensive medication because they may have been on it for years, that they're on aspirin. And if they say they're on aspirin, for example, you want to know why they're on these drugs. If they don't know, you need to find out. So the GP's letter is a primary thing that we must consider, and after that you must consider what medication the patient is on. And then you proceed to the medical history, and as always I'll be terribly formal, and you introduce yourself to the patient and say, welcome to the outpatients, thank you very much for coming, and explain to them what you're going to do. So you're going to say, I'm going to ask you lots of questions and I'll interrupt at times, so bear with me, and if it's not clear, if it's too much jargon, let me know. So the first thing I ask you, Donica, if you don't mind, is what age are you?
I'm 20.
20. And I'll write as I go if you don't mind, because I'll have to dictate a letter to your GP later. And are you right or left-handed?
I'm right-handed.
Right-handed, thus implying very strongly that your speech hemisphere, your dominant hemisphere, where your speech resides, is on the left-hand side. And your occupation?
I'm a student.
A student, okay. So you need to make sure you don't see any people working with industrial waste and things like this, and people who work with birds and various industrial disorders and infectious disease you might be exposed to. So what I tend to do is, I know you've got, the reason your presenting complaint is one of headaches, but just to clarify that in case I'm missing something, I go, have you any past medical history?
No.
Nothing of note. Have you ever had an operation or anything like that?
Minor surgery.
Minor surgery, okay. Are you allergic to any medication that you're aware of? Okay. And then I always ask about chronic illnesses that people might take for granted almost, believe it or not. Are you diabetic?
No, I'm not. No.
And do you have high blood pressure?
No.
And have you ever had tuberculosis?
No.
Okay. Have you had any foreign travel in the last 6 months?
No.
No, okay. And are you on any medication at the moment?
No.
No. No prescribed medication, but are you on any over-the-counter medication? Do you take anything?
I take some Solpadeine.
Solpadeine, okay. Well, that's very important, and we'll find a bit more about that later, the dose, etc. Are you married?
No.
Do you have any dependents?
No.
Do you smoke?
No.
Do you drink alcohol?
No.
And is there any family history, any history in your family, of headache or migraine?
Oh, my gran used to get migraine.
On your mum's side or your dad's side?
My mum's side.
Okay. Now, you've been sent by your doctor with a history of headaches. Now, I don't want to assume these are migraine or any type of headaches in particular, so for how long would you say you've been having headaches of any description?
I'd say for about 3 years now.
So about 3 years. And are they all the same type, or do you have different types of headaches?
Well, most of the time I'll have a constant headache in just the front part of my head.
Okay, so over the front of your head, and that'll be there kind of 24 hours a day, 7 days a week.
Yeah, most of the time. Yeah.
And would you describe that like a stabbing pain, a sharp pain, or more like a grip-like pain, a vice-like grip?
Kind of the last one I feel.
Right. And would that be worse at any particular times?
I haven't noticed.
Say, for instance, doing exams?
Well, if I'm stressed, it'll become worse.
Okay. And what would you take when you have one of those headaches?
I have a Solpadeine.
Right. How many Solpadeine would you say you take per headache, or more importantly, how many would you take, roughly speaking, in a week?
suppose probably about two every time the headache gets bad, and then
Okay,
I'd
so
say that's maybe 10 times a week. So
10 times a week. So you could take quite a few Solpadeine per week. Okay, that's fine. And with those headaches, now just stay with those vice-like grip headaches, tension-type headaches, which I would wager they are there any other symptoms that affect your vision, your speech, your swallow? Does it affect your arms or legs?
well, my eyes been very sensitive to bright light. So,
Okay,
it could kind of affect my vision.
right,
Slightly.
but nothing else. Now, you then mentioned that you get more severe headaches on top of that. So we'll call that first type of headache type A headache. The second type of headache you get, the more severe ones you get, and how often are they occurring over the last 3 years or so? Again, rough guides are fine, we don't need specifics.
Once or twice a month, I'd say.
So once to twice a month. And if you talk me through one of those more severe episodes, how do they start? So say for example, I always ask, how does it start? So say you're going to have one in front of me right now. What's the first thing you'll notice?
My vision will probably go very blurred. I'll have blurred vision.
Blurred vision. And how long? So how long will the vision be blurred for before the headache kind of kicks in, if you like?
I'd say anywhere between 20 minutes and an hour.
Okay. And then after 20 minutes and an hour, you'll find that you develop a headache. And can you describe that headache to me, please?
It's like it's a pain on one side of my head.
Is it if you take one of these words, is it sharp? Is it stabbing? Is it burning? Is it throbbing? Is it lancinating?
I'd say it's throbbing.
Throbbing. And is it more? It's on one side generally. Okay. And in that situation, do you think does bright light bother you or loud noises?
Yeah, the light would definitely get to me, and I've become very sensitive to any kind of noises around me.
So what would you normally do in that situation? So say, you know, in evolutionary terms, what would you say, what would I do if I'm in that situation? What would you do?
Well, normally I feel quite nauseous as well, so I head straight on to bed kind of.
So you go to bed, and once you fall asleep, do you wake up and the headache's more or less gone?
Well, yeah, sometimes.
Right. Would you take more Solpadeine at that point?
I would, yeah.
Okay. So once to twice, on 1 or 2 occasions a month, you'd have these more severe headaches superimposed on a more baseline tension type headache. And with the more severe headaches, again, the same question, do you have any other symptoms? Does it affect your speech, your swallow, your arms, legs?
Sometimes I get a tingling on one of my hands.
Tingling in one of your hands, okay. But it doesn't affect your speech or swallow. Okay, well that's very clear. So those type of headaches would now seem to me to be much more like a migraine headache. So the baseline headache is a tension type headache, and for that you're taking probably an excessive amount of over-the-counter medication, and Solpadeine is a drug that contains codeine, and this can be mildly addictive, if not quite addictive. And I always see it as this, that if you take too much codeine, it'll take the edge off the baseline tension headache, but then you get a rebound headache, and therefore you become gradually more dependent on the Solpadeine. So as a result, you've then got a combination of headaches of tension headache and medication overuse headache. Then, the reason for you taking any of this in the first place is for fear of what are probably migraine headaches, the classics. So suddenly we've gone from headaches that the GP says that's just headache, to 3 different types of headache. And once you explain this to the person, they say, oh, okay, well that makes sense that you've got tension headaches because you're worried you might have a migraine as well as the stress of life. Then you take too much medication, you develop a medication overuse headache, and now you've got 3 different types. So it's not as simple as just saying, oh, that's migraine, here's the drug, good luck. So the next thing we do is just to ask a few other basic questions is, which are, do you grind your teeth?
Not that I noticed, no.
Bruxism is tooth grinding, which sometimes can cause instability of the temporomandibular joints, and again lead to tension type headaches, and easily treated with a nocturnal brace in some situations. So the next thing we do then is examine the patients, having done the background history. There's a family history of migraine, so that will predispose you to all these things, and then we examine the patient in a fairly brief manner, and we decide then on therapies we might employ. Okay, Danica, having taken the full history, I'm clear in my mind now what I think is going on, but of course I'm going to do a brief examination just to make sure I'm not making any assumptions. And that's a brief neurological examination looking at eye movements, walking, that kind of thing. So if you don't mind, I'll ask you to stand up and come on over here. Okay. So having discussed your history, and I know that you're a healthy guy with no past history of note, for the clinical situation I do a brief neurological exam just to make sure I'm not missing anything. This examination is purely for the office and wouldn't apply in examination circumstances for students, for example. So I will be cutting quite a few corners here. Okay, Donica, I'm just going to do a brief neurological exam the way I normally do in the clinic. Okay, so first of all, thank you once again. I'm going to examine your face, then your arms, and then your legs. Okay, so it's a brief one. So the first thing I ask you is, have you noticed any change in your sense of smell?
No.
Okay, and your vision is unchanged?
Yeah.
Okay, can you take off your glasses momentarily, please? I'm going to ask you to fix on my chin here, okay? And I'm going to move a finger. I want you to tell me which one moves. Just point to the one that moves. Thank you. Great. Okay, now I'm going to ask you to follow my finger. So keep your head still and look at my little finger, okay? So no ptosis, pupils are equal, no nystagmus. Head still now. If you can look out to the left. Do you see one or two?
Just one.
Okay, and keep following that. You're doing brilliantly. One or two?
One.
Come up to the sky. Great. I'm going to hold your eyelids as I come in close to look down. So you look down. I'm going to hold your eyelids. I won't hurt you. Fantastic. Now, can you look to your left, to your right, to your left, to your right, please? Perfect. That's great. Now, I'm just going to touch you on the face. So if you could close your eyes, can you feel me touching you there?
Yeah.
And there?
Yeah.
Does it feel the same?
Yeah.
And here? And here? All the same. Okay. Now, can you raise up your eyebrows as if you're surprised? Frown down as if you're angry. Squeeze your eyes tightly shut. Okay, open quickly. Show me your teeth. And blow out your cheeks. Fantastic. Have you noticed any change in your sense of hearing?
No.
No ringing in your ears or anything like that?
No.
Okay, and can you open your mouth wide for me? Head back a little bit and say ah, and swallow is okay. Okay, can you put your chin onto your chest? I'm going to put my hand in your forehead. Don't let me hurt you, but push against my head. My hand, I mean. Push hard. Wonderful. Okay, that's great. And finally, can you open your mouth once more and stick out your tongue straight? Perfect. That's great. Now I'm going to have a little look in the back of your eyes. I'm looking for a sense of pressure behind the eyes or papilledema. So I'm going to use a light here. I'm going to ask, that light is going to go towards your eyes. I want you to focus on the top corner of the door there. Okay? So I'm going to come at you, if you like, and look in the back of your eye. It doesn't hurt, but it's a bit disconcerting. Great. Okay, so I can see the disc margins fairly easily. Want yourself there. Same again now with the left. Perfect. No problems there. You can put your glasses back on. Thank you. So that's the cranial nerve examination. So then I move on to the arms. So I'm going to take your hand if you don't mind. There's no soreness anywhere, is there?
No.
Okay, I'm just going to move it around to get a sense of the tone. And I'm going to use both hands at one time just to get the tone. That's fine. Now, can you put your arms up like that for me? And push up against me, but don't let me hurt you. Push up. Now push down. Great. Like that. Pull me towards you with your right, towards you, and push me away. Well done. Towards you and away. Great. Can you put your hands out straight? And cock up the wrists. Don't let me bend them. And now push me away with them. Well done. And the hands out straight. Don't let me bend the fingers. Keep them up. And spread the fingers wide apart. Don't let me push them together. And turn the hands over. Grab my fingers and squeeze as tightly as you can. That's great. Now you can rest them back in your lap. I'm just going to test your reflexes. So if you relax as much as you can, I'll work around you through your right angles of your arms. Okay, now, normally I might undress someone at this point if I wasn't sure, but usually in a clinic situation you don't need to. When I say now, will you grit your teeth? Okay, on 3. 1, 2, 3, now. Great. Now. 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 Bring your hand across here, please. Okay. Great. And if you just rest your hand on mine and let the hands drop down. That's wonderful. I'll just do Hoffman's. That's fantastic. So that's the upper limb. Now I'm going to examine your legs, okay? So you can put your glasses back on. Thank you. All is normal so far. Now, in your own time, if you kick off your shoes, if you don't mind, you don't need to take off your socks. And just lie back there. Okay, you comfortable enough? No pain in your legs as well? Same questions, really. Okay, I'm going to move your legs around a little bit, just to get a feel for the tone of them, and then I'm going to pick them up fairly smartly, like that. Okay, so that's normal. Now, with your right leg, can you lift it straight up in the air like a ballet dancer? Keep it up, and now bring it down. Okay, the left, up, and now down. Great. Can you bend up both knees? Don't let me straighten it, your knee. And now kick it out straight. Great. Don't let me straighten this one, and now kick it out straight. Okay, can you cock up your feet this way? Keep them up, and push me away. And away. Well done. Easier said than done. Now, I want you just to test your coordination. Can you take your heel and run it down the side of your leg like that? Okay, and now can you do the same with your left leg? Once it's grossly normal like that, there's nothing to worry about. I'm going to test your reflexes now. Okay, and the other one, if I may. Great. Now, can you bend up your right leg and flop it out towards me? I'm going to tap your ankle. Okay. And can you bend up your left leg and flop it away from me, please? Great. The last thing is a bit uncomfortable. I'm going to scratch your foot fairly smartly. So I always say, I'll apologize, but I don't really mean it. So I'm looking for the movement of the big toe. And once it's clearly down like that, even through the sock, I think is sufficient, although purists would disagree with me and you should remove the sock. I'll do one more thing then. Test sensation in the lower limb. I always use tuning fork. Can you feel that vibrating?
Yeah.
Okay, so a 128 hertz tuning fork. I'm going to place this on your toe. Can you feel that vibrating?
Yeah.
Close your eyes now, and there?
Yeah.
Okay. Once that's all normal, there's no symptoms of sensory loss or of motor loss, I think it's sufficient to do that for a brief neurological exam. Thank you. Okay, well, Donncha, I'm glad to say your neurological examination is entirely normal, so you have nothing to worry about. And once that's the case, I can reassure you that you really don't need further tests. Now, when people are referred to the neurology clinic, many neurologists will say, well, you don't need any further tests when the exam is normal. I must admit, I find that people are under a lot of duress. They've seen their general practitioners a few times. So I think it's not a bad thing, because it's a chronic condition, particularly migraine, to do a CT scan, or indeed even an MRI scan. Now, I'm aware that there's radiation involved and there is a slightly increased risk, but ultimately I believe, and there is a debate on this matter, that people should have a scan if they've been waiting in the Irish system long enough to come to see a neurologist, and at this stage their anxiety levels are usually quite high. But assuming the CT scan, which is more than likely to be normal, and in an older population one would also do a blood test called an ESR, and that's looking for temporal arteritis. But assuming these things are normal, we then explain to the patient the sequence of events in terms of how to manage their headaches. The first thing is one must always do is try and empower the patient so they understand what's going on. To do that, I often give them a leaflet to say, have a think about it. I've given you an awful lot of information today to say I think you have 3 types of headaches, tension headache with medication overuse involved and migraine superimposed. So as a result, it's quite difficult to take all that in and walk out and say, oh, and despite our best efforts not to use jargon, I'm sure some of the words we use are alien, unbeknownst to ourselves, or despite hopefully our best efforts. So we give you some information to say, this will describe to you remind you what I'm saying, what I've said today, I hope. Now, but more importantly, I'd like you to take control of this situation yourself in as far as you can. So I always recommend that people use a migraine diary, which are kindly supplied to us by the Migraine Society of Ireland, Association of Ireland. And what this does, it gives a diary to say, on every day you have to do a little bit of work yourself. And the first column says, there's the day, and so if you have a headache on that day, it says, what time does it start, the headache? How long does it last? And is it bad, really bad, or really, really bad? So intensity is low, medium, or high. And then, can you still do what you normally do? Can you go to work? Can you study? And do you have any other symptoms, such as those you mentioned, blurred vision, tingling in your hand? And then, did you take anything for it? Because this also helps people who think, no, I only take the odd Solpadeine or whatever. In fact, they suddenly go, well, actually, gosh, I'm taking 20 a week, as you've kind of even found out yourself in this interview. And then you identify any possible triggers. Did you go out late the night before? Did you drink too much wine? Did you eat too much cheese? Chocolate tends to be precipitant, as you probably know. And in this day and age, you've probably, particularly as a student, Googled all of this at this juncture anyway, and probably quite well informed. Patients tend to be much more well informed these days and have made it quite an effort to look into these things themselves before going to doctors, which I think is a great thing. So I'll ask you then to fill in that diary when you go home. Here's some further information, and I probably will arrange a CT scan and an ESR, which you can almost certainly assume are normal, but it's more to reassure you than anything else for the future. The next major part of the plan is to stop all over-the-counter medication. So this tends to frighten patients quite a lot as well. They go, oh, this is a crutch they've now, that has now evolved, and we need to take that away a little bit. So you need to cut out, slowly if you wish, if you feel you can't bear it, the amount of Solpadeine or Nurofen or any over-the-counter medication you're taking each week, to the point that you're taking hardly anything. Now, you'll find that that will then ease the amount of what vice-like headaches you're getting, because it's a combination of medication overuse and tension that's causing those. Then if there is temporomandibular joint instability, I'd ask you to see your dentist to give you a brace that you can fit and just wear. It's like a mouth guard or a gum shield you wear in rugby that you wear at night, and that eases tension in the muscles. It stops tooth grinding or teeth grinding. And then the options are to treat the migraines themselves. You can either treat it acutely or prophylactically. I don't tend to treat with prophylaxis only if people's quality of life is severely affected, by which I mean if they're having more than 1 or 2 severe migraines a week almost. Now others will treat when it's only 1 or 2 a month. But you work that out with the patient as to what they want. Some people are very against having any medication at all, because inevitably they all have potential side effects. So what I would say to you that if you give it a little time with the diary and you can try and do everything without medication primarily, that'd be fantastic. But I'll write a prescription here for you today for the acute situation when the blurred vision and you feel one of these throbbing unilateral migrainous type headaches are coming on, called a triptan. The drug is called a triptan that I'm writing for, and you take one at the beginning of an attack and you take it within 2 hours if it's not gone. But you don't take more than 2 within 24 hours because of potential side effects. And one always looks up the past medical history, of course, to see if there's any history of heart disease. We don't give it to pregnant women, but I won't go into that too much detail. You can look that up yourselves. So triptan is the one. There's a family of drugs which work through the serotonin system, which work fantastically in severe migraine. And you can take these acutely. If they don't work and you come back in a month or so's time and you say you're still having lots of headaches despite this, I'll say, right, perhaps it's wise to give you some preventative medication. And the preventative medication I would use first line would probably be propranolol, which is a beta blocker. And I give it 10 milligrams 3 times a day for about a month, and then increase to 23 times a day, and then 33 times a day. And that seems like an awful lot, but it's not really. The major thing, of course, is you don't give it to someone who's a history of asthma. If it doesn't work, and again, the diary I always say the diary is like a report card, and you can say, well, oh look, you got good results there, doctor, or no, you didn't. So you didn't do so well there, doctor. You say, well, fair enough, not a disaster. You wean off the propranolol and you move on to second line. And if the second line I now use is a drug called topiramate, and you start at 25 milligrams a day and increase over 4 weeks to 50 milligrams twice a day, and you take that for at least 4 months, and then you wean it off. Again, I always say it's like a MyWadi or a cordial drink, where you take a small dilution first and make the concentration increase, and then you dilute it again later on. So the patients understand what you're doing, and you're not, in their own words, poisoning them. So take 50 milligrams twice a day of Topamax for 4 months at a minimum, and you can take it for longer. And their side effects of, excuse me, the side effects of that primarily are weight loss, pins and needles in your hands, and very rarely language disturbance, are the 3 I always warn people about. Finally, if that doesn't work, my third line is usually Pizotifen, which is Sanamigrant, which is 0.5 milligrams at night, increasing on a weekly basis to 3 milligrams. And the main side effect there is weight gain. So you choose your audience, so to speak, by potential side effects for people, and depending on the individual, what drugs are effective. When you're looking at someone with headaches or chronic daily headaches, you have to think, is it a primary headache or a secondary headache? All I've been talking about earlier on today in this piece is primary headaches. They are those without a clear-cut structural cause. Sometimes, however, the situation is much more acute. If someone comes to a general practitioner or indeed to the emergency department with an acute, severe headache, they always describe it as the worst headache they ever had. The first thing you must rule out is a subarachnoid hemorrhage. Usually people describe it as if they've been hit hard with a baseball bat for some reason at the back of their head. They feel nauseated and their neck is stiff. In that situation, they need an urgent CAT scan and perhaps even a lumbar puncture. The second thing you must rule out is meningitis. and that will be there'll be markers of that, a more generalized unwellness, and much more clearly obviously unwell, usually more clearly obviously unwell than someone with a chronic 3-year history as Donncha has described today. The red flags that we look for are for things that might suggest an underlying tumour, a bleed or hemorrhage or an infection. And these are neurological signs, symptoms of meningism, and the consistency of the headache are crucial. And in which case, if you're in doubt, then someone should be imaged, in my view, fairly smartly. For the other type of headaches, we've discussed medication overuse, migraine, and tension headaches. But if it's not those, there are other types of headaches, such as cluster headaches, paroxysmal hemicrania, hemicranialis continua, and these type of headaches have different markers. And we often see autonomic signs, such as injection of the eyes, redness of the eyes, or ptosis, or drooping of the eyelid with these. And again, these follow quite a pattern, but the common ones are the ones we've discussed here today.